So in this session, we're going to look at perspectives on the future of consent in clinical research. And the way we'll go about this, I will give a very quick overview for about 5 minutes about the innovation work package that we did within iConsent. And then we'll move on to our presenters. We have Professor Søren Holm talking first about the consent solutions for secondary use of trial data after the end of the trial. And then we'll move on to Dr. Marcello Janka, who will be discussing the implications of big data for informed consent. So hopefully you can all see my screen. I have to work out how to go to the next slide. 1 second. Okay. So when we began the work on innovation and informed consent, we were working with the main problem of consent not being personalized to and what that meant is that we were not able to communicate consent well, and we're also aware of the fact that informed consent hadn't changed for decades. So the way we approached this problem is we did a mixed methods approach. We used systematic literature review and literature review. We did this to get secondary insights. We then aimed to get primary insights from the population using qualitative and quantitative mixed methods. And we also combined that with a design thinking approach, which I will tell you about in a moment. And then we combined all of these insights using expert opinion, and we generated recommendations. So we covered 6 main areas. We looked at global initiatives and trends in informed consent, the impact of technology on informed consent. And we did this through a lens of gender, particularly the involvement of women. And we also looked at age and culture, particularly. We approached ethical, privacy, and data issues, and that was what Sylvia was describing in more detail a few moments ago. We looked at health literacy, and we also explored the patient-clinician dynamic. And so if we start with the literature review, the existing body of evidence that we had, when we looked at it, we realized that technology was evolving really fast, so it wasn't all captured in the literature. And on top of that, there was a lot of heterogeneity. So the tools were different in different places, so were the communities, the studies, and the topics. And what we found that was comparing all of these different tools to figure out which ones were, say, better or worse, was actually impossible through meta-analysis and challenging with the SLR. The main message we got from the literature was that there was no one best way, and that it would have to be quite context specific. So then we moved from the desk and into the community to try and expand on those insights. And we used a mix of different methods to get different perspectives. So the traditional methods we used were key informant interview, focused group discussion, and face-to-face survey. But because of the evolution of technology, we also use different tools and communication channels. So if you think of the case of a mother who's just given birth, she has constraints on her time, finances, transport, health, and work leave. And while it might be difficult to access her through the settings where she would normally be before she'd given birth, after birth it was more challenging, but we thought that we could reach women who had just given birth, say, through social media to gain insights, and also to recruit them for studies. So we used social media, specifically Facebook, and we managed to get 3 main outcomes. We got qualitative insights, we could monitor change in perception of the community over time, and we were also able to follow the trajectory of messages in real time to enable intervention. And I won't go into any of these in a huge amount of detail, I'll just flick through some slides to give you an idea. For qualitative insights, we use natural language processing to gain a polarity score for each word or comment, and that enabled us to basically map out all of the comments and be able to select extremes, which was helpful for human-centered design. So if you have an extreme comment like these, for example, we had the most positive and negative comment here, we were then able to do a qualitative analysis looking for themes that was similar between both the positive and negative, and also where those different perspectives differed. That was quite insightful. We were also able to monitor change over time. So here, for example, there's 2 posts 1 year apart, identical posts in the local paper in Italy. And what it's showing is that we could use natural language processing to see different scores from one year to the next. We were also able to follow the trajectory of messages in real time. So this is just it's basically a post that got hijacked, we'll say, by anti-vaxxers. And it meant that it went from being a very positive post to a very negative post in the community. And we were able to intervene, or we could have intervened in this or in other cases if necessary. The other approach we did was design thinking. We did a lot of focus on this. To give you an idea of what that is, it's an approach that's quite new to healthcare. It's been used in other fields, more the design field. As you can see here, there's 5 pillars. At the beginning, you empathize. So you look at the problems that need to be resolved and identify the needs, then you define them. You ideate and you prototype, and then you test. So the idea is this very rapid cycle with everybody involved, so patients and other stakeholders. And I'm just going to show you some photos of that. This is us building empathy with some patients and families through role play. This is about vaccination. This was about processing feelings. So some more of our child patients. Here we generated and structured ideas. Here we're voting on which ideas are best. And here we were building basic prototypes out of cardboard with cultural mediators, researchers, and patients. Another thing we did is a survey. Just one quick outcome of this is that our researchers in the network seemed favorable to the adoption of technology, which is very promising. So I won't go into all of the findings, but what we did do is identify basically pressure points in the system, places where we thought that we could elicit the best change, and we've developed this. This is the theory of change. The idea is that if you basically have an informed consent that is more inclusive, that will improve your quality of your research. You'll have better representation, higher recruitment rates, lower dropout rates, etc. Research that's of higher quality, social value driven of lower cost, and eventually that will give you healthcare that's better and designed for all. Just to give you a quick idea of the type of interventions, increasing health literacy, channeling funding to underrepresented groups, improving recruitment team diversity, tailoring informed consent to the local context, using design methods that put the community at the center, and using technology to personalize informed consent to individual needs.